Hi, my name is Marie Romagnano, founder of Healthcare Professionals for Divine Mercy. I'm so happy to present to you our educational conferences that integrate medicine, bioethics, and the spirituality of Divine Mercy in patient care for healthcare professionals. Because of their importance, even if you're not a medical professional, we invite you to join us. Today, I wish to summarize for you Dr. George Delgado's conference, The Abortion Pill and Its Reversal, that could save many babies' lives for those who changed their mind after taking RU-486 and thought it was too late. But it isn't too late. Dr. George Delgado, Associate Professor at the University of California, San Diego School of Medicine, discusses the abortion pill now in use, their complications, and the use of progesterone to reverse the effects of the abortifacients. The drug mifepristone, commonly known as RU-486, was the first medication used to prevent pregnancy. It binds to progesterone receptors and blocks the implantation of the fertilized ovum. This drug is used in approximately 25% of abortions in the United States and 80 to 90% of abortions in Europe. It was hailed as the holy grail of abortifacients, since this pregnancy termination pill could be taken at home and involve no surgery, despite the fact that life-threatening vaginal bleeding and infections could occur. Dr. Delgado's first case was a woman from Texas who had taken mifepristone to induce abortion and then changed her mind. He theorized that using progesterone might override the blocking effects of the RU-486, resulting in the implantation and development of the embryo. He knew that time was of the essence, and he had a doctor in Texas give the injections of progesterone, and it worked. The baby is now 5 years old and perfectly healthy. It worked because progesterone causes development of the endometrium for embryo implantation, relaxes the myometrium, and promotes the development of breast milk-producing cells. Misoprostol, Cytotec, is a prostaglandin analog that is a more effective abortifacient than RU-486, and it's approved for use of up to 49 days after the last menstrual period. The rate of fetal survival is less than 1% if given in that time period. Many doctors use the drugs in combination for maximum effect. Misoprostol may cause facial nerve paralysis, and this tends to occur more if given in the 5 to 8 week gestational period. One question that mothers wanting an abortion reversal will ask, will it harm my baby? Will there be birth defects? The FDA published a report in 1999 that found no increased incidence of side effects. Dr. Delgado's findings indicate a successful rate of reversal at just over 50%. If you found this valuable, please listen to Dr. Delgado's full conference talk as he discusses the use of progesterone to reverse the effects of the abortion pill and save the babies' lives. Thank you.
We're going to talk about the reversal of mifepristone RU-486. I'm going to tell you a little bit how I got started in this and what it all is and what we can do to help these women. And I think what's very important is to realize, and sort of like Father Chris was saying, this is certainly, it's a battle. And from the way we deal with it, it's a biochemical battle. We're trying to block a chemical that's trying to block a natural hormone. But fundamentally, this is really a spiritual battle. I think we cannot forget that. And all of your prayers and all of your sacrifices are very important in helping these women who are in these crisis pregnancies. Number one, helping them so that they see that there is another way out of their situation, that they don't have to choose death. But secondly, for those who do choose death by taking the abortion pill, that there is an opportunity, that there's a safe and effective way to reverse the mifepristone, the RU-486. So we really have to keep that in mind, that it's not all about us. It's really on a higher spiritual plane, that it's the dominions and the principalities, and we have to always keep that in mind. This is our APR medical team. I'm the medical director, and Dr. Matthew Harrison here is our associate medical director. And we have a nurse coordinator, Debbie Bradle, as well as Sarah Littlefield, our coordinator, and several volunteers. And Dr. Harrison, he actually performed the very first reversal of mifepristone RU46 back in North Carolina in 2006. The baby was born in 2007. He got a call from a pregnancy resource center who had a woman come in who had taken mifepristone RU46 and was wondering if it could be reversed. Well, he had had some experience with progesterone, and he thought to himself, well, I've never heard of this being done, and I'm not sure if this can be done, but I certainly think I can give it a try. And so he treated her with progesterone, and he was able to save the baby. So it was a great thing, and that was the first documented case. He didn't publish that, or he didn't really make that case well known. So fast forward 2 years later, in 2009, I got a call from a sidewalk counselor in Bakersfield, California, by the name of Terry Palmquist. And Terry has a website called Lifesavers. Not only does she help women there locally, but she gets calls from women all over the country who are in crisis and who are seeking help. And so Terry called me one day and said, well, there's a woman in El Paso, Texas, who took mifepristone RU46. She wants to know if we can reverse it. I thought to myself, my goodness, I've never heard of that being done. I've never read about it. I certainly knew a lot about mifepristone because when it came out and it was approved in 2000, I had studied up on it. I wanted to know how it worked and what it was all about because I knew that this was going to be growing in the United States. And I had a lot of experience using progesterone in pregnancy because of my naprotechnology training. We use a lot of progesterone for treating women who have what we call threatened miscarriages. So these are women whose bodies are showing that they may be having a miscarriage. Sometimes it's due to low progesterone levels. We can give them extra progesterone, and that can prevent the miscarriage. So then I knew that the mifepristone acts by blocking receptors that are normally there for progesterone. We'll talk a little bit about that later. But by blocking the progesterone receptors, the progesterone cannot do its good work in the uterus and in the placenta. And so essentially the baby is starved to death and the baby dies. But I envisioned, well, this is kind of like a battle of soldiers. And I thought, if we can get more of the good soldiers, the good guys in there, we can outcompete the bad guys, and maybe we can stave off the attack of the mifepristone. So I came up with a protocol, and I decided, okay, this is how we could treat this woman. But then I had a problem. I was in California, she was in El Paso, and time was of the essence because the clock was ticking, and that poison was starting to work on her placenta. So I looked up a doctor who I knew was trained in naprotechnology, Dr. Jonalyn Bellacura, and I called her, and fortunately she was in the office and took my call. And I told her the situation, and I said, do you have progesterone in the office? She said, yes, I do. I said, fantastic, this is what I'd like you to do. So I laid out a protocol for her and asked her if she'd be willing to go ahead and do that, and she was. She treated this patient, and the patient was quite grateful, and her baby survived and was born at term and was very healthy and happy. And we were able to save that baby. So from then, I started getting calls from people around the country who had heard about this. I think Terry started telling people in the pro-life community, and pretty much word started spreading. And then I had my own San Diego case, I think was patient number 3 or 4. Pretty soon we had a case series going on, and we thought, well, this is something that really might work. So we published the study that I'll go over in just a second, and then started getting more calls. But every time a doctor or a pregnancy resource center, someone would call, it was always a struggle because we had to find a doctor in that area who could treat that patient. And we had to scramble around and took a lot of time. And of course, the clock was ticking with every case because the longer the mifepristone has been on board, the less chance there is of a successful reversal. So I finally realized that we need to have a network of doctors all over the country, doctors who are willing and ready to retreat these patients so that we don't have to spend hours and hours on the phone searching for them. And I also realized that a lot of these women were finding out about this after a lot of searching and phone calls, and that was wasting a lot of time. So at that point, we decided we're going to establish a website and a 24-hour hotline. And so we have a website, abortionpillreversal.com, and I welcome you to visit it whenever you have a chance. And we have the 1-800 number that's available 24/7, staffed by nurses. So that was a way to get the word out to the patients, to those women who are in crisis, because of course these days, what do young women do when they want information? They either go on the smartphone or go on the computer and they go to one of the search engines, typically Google, and that's how they find out all their information. So if you type in abortion pill reversal, we come to the top, which is very, very fortunate for us right now. And then now we have these doctors. We have over 270 doctors in our network now. So we're getting more established so that when someone calls now, it's a lot easier to find someone. But we're still trying to increase our numbers. Here's a paper we published. Dr. Mary Davenport, my colleague, and I authored this in December of 2012. And as Marie said, this is as far as I know, still the first article in the medical literature about abortion pill reversal. So it's in a peer-reviewed journal. So this is a respected journal, the Annals of Pharmacotherapy. This was a case series of 6 patients in whom reversal was attempted, and we'll talk about those patients in a second. Let's talk a little bit about mifepristone and exactly what it does. Mifepristone is a progesterone receptor antagonist. Okay? So for those of you who don't have a good medical background, all hormones work by going through the bloodstream, attaching to a receptor, and then that produces what's called the hormone effect. Now, an agonist is something that does what the hormone does. So the hormone itself is an agonist, and you might have other drugs that are also agonists. For example, things called progestins. They latch onto the receptor, and they pretty much cause the same effect that the progesterone does, which is the good effect, which is what the pregnancy needs. And indeed, progesterone is called progesterone because that's an acronym. It's an acronym for progestational steroid. And so the chemical itself is really to help gestation, to help pregnancy. Well, mifepristone is an antagonist, and that means it does latch onto the receptor, but it blocks the effect of the receptor. So it doesn't trigger the hormone effect. It just simply sits on that receptor and blocks it. So that's why it can be counter-progesterone. It's an anti-progesterone in the body, and that's why it can cause a medical abortion or a chemical abortion. What about progesterone? So what does progesterone do that's so important? Well, progesterone is very important for those of you who know the physiology of the menstrual cycle. The second part of the menstrual cycle is called the luteal phase, or sometimes called the secretory phase of the uterus. And that's when the lining of the uterus, which has been thickened under the influence of estradiol or estrogen during the first part of the cycle, after ovulation, the corpus luteum, which is where the egg was released, that then starts to produce progesterone. And what progesterone does is it solidifies and stabilizes the lining of the uterus called the endometrium so that it's receptive. Every single month a woman is menstruating and ovulating, her uterus, the lining is receptive to a new human being coming down the fallopian tube about day 5 or 7 and implanting. So that endometrium has to be ready, and the progesterone is what gets it ready. So it's a very receptive environment for that embryo. Now, if that woman does become pregnant, what do we want the uterus to do? We want the uterus to stay nice and relaxed and to stretch out to accommodate that baby. So the progesterone also causes the myometrium, or the muscle of the uterus, to relax, to not contract. What do we want the cervix to do during pregnancy? We want the cervix to be a biological valve, to be closed tight. So the progesterone keeps the cervix closed. In the breast, the progesterone causes the development of the cells that produce milk, gets them all ready to produce milk, but it inhibits milk production. So it's a perfect design that God gave us. The women's breasts are ready to produce milk, but they're not producing milk until progesterone levels fall at the time of delivery. That helps trigger then milk production. So this is a little diagram showing here the decidua basalis. That's the part of the placenta that comes from the mother. Most of the placenta comes from the baby. It's called the chorion, but the decidua basalis comes from the mother. And so here is where you get separation under the effect of mifepristone. You get separation of the placenta, and that leads to starvation of the baby and the death of the baby. And this is the myometrium, the muscle that I talked about, and then the cervix down here. So the mifepristone will have effects all throughout. So mifepristone has been available in the US since the year 2000. By 2008, approximately 25% of all early pregnancies were being accomplished with mifepristone. These days, 18 to 25% of all abortions are being accomplished with mifepristone. So that's about 200,000 to 300,000 abortions every year being accomplished with this abortion pill. In some European countries, the rates of medical abortion are more like 80 or 90%. So we're not quite there, but that's where we're moving. And when mifepristone was approved, it was hailed as a holy grail, as a great breakthrough for women by the pro-abortion advocates. And the reason why is because, of course, there's no surgery involved, but also because it's the opportunity to remove the abortion from the medical setting and to make it a more private affair, to make it a less medical affair. If you could get hold of the medicine and take it at home, you wouldn't have to depend on a doctor, on a clinic, or even depend on any laws. And indeed, there are websites available for women in foreign countries where abortion is illegal that teaches them how to do chemical abortions with a drug called misoprostol, which I'll talk about in a second. So the whole aim is to sort of, quote, empower women so that they can accomplish these abortions without the assistance of medical providers, or at least with very minimal assistance. And up to now, more than 2 million babies in the United States have been aborted with mifepristone. Now, 2 days later or so, mifepristone is followed by a second drug, misoprostol. And let me explain why that is. I told you about mifepristone is what kills the baby. Well, 20 to 40% of the time, the uterus does not completely empty. So in order to completely empty the uterus, because what abortionists are interested in, of course, is a complete abortion, which means that everything's out, and then the woman can at least theoretically go out on her merry way. Well, the misoprostol is the second drug, and misoprostol is what we call a prostaglandin analog. Any of you women who've ever had induction of labor may have had a first drug given first that's so-called ripened the cervix, and that was a prostaglandin analog. And that's what misoprostol does. And in fact, misoprostol can be used to induce labor. Well, it causes the uterus to contract. Contracting, then of course it empties out the uterus. The embryonic remains are then pushed down. So it's a 2-drug cocktail with 48 or 72 hours between the 2 drugs. The FDA-approved protocol was using 600 milligrams of mifepristone RU46, and then on day 3, 400 micrograms of misoprostol, also known as Cytotec. On day 14, they're supposed to confirm that indeed the embryo has died. There are off-label protocols, and these days in the United States and probably through most of the world, the off-label protocols are being used. And what an off-label protocol means that the FDA can approve a drug, let's say a heart drug, to treat a heart condition, but doctors later on may find out that that drug is also useful, let's say, to treat high blood pressure. Well, the doctor has every right to prescribe that drug for high blood pressure, knowing if there's enough evidence that it works, even though it's only specifically approved for heart disease. So the same thing has happened right here. And early on, it was found that mifepristone, anywhere from 100 to 600 milligrams of RU46, were equally effective. So it didn't matter whether you gave 200, 400, or 600. All the doses worked about the same in their effectiveness of killing the embryo. And it's a very expensive drug. So early on, they decided they were going to go to the lower dose. And that's why the off-label protocols now use 200 milligrams instead of the 600. Well, the misoprostol, they found out actually that if they gave higher doses, it was more effective at causing the uterus to contract and to empty out the contents of the uterus. And so that's why they went with the higher dose. And misoprostol, or the Cytotec, when you do take it orally, it can cause a lot of upset stomach and diarrhea. So in order to avoid those side effects, it's now given between the cheek and gums, what's called buccally. If you slide it right between the cheek and gums or under the tongue, it actually gets relatively well absorbed. Or even more commonly, it's given vaginally, and that's to avoid the side effects. In the FDA trials, the rates of incomplete abortion were 5% if it was given before 7 weeks, and 7 to 8% if it was given up to 9 weeks. Now, it's important to remember, and we'll come to this a little later, what I mean by incomplete abortion, it does not imply that the embryonic human survived. Incomplete abortion simply means that the uterus was not emptied completely. That's what the definition of incomplete abortion is. In those studies, the rates of the embryo actually surviving, of life being detected after the attempt, were less than 1% at 49 days, and 9% if given up to 63 days or 9 weeks. Now, the studies of mifepristone alone are far fewer because, like I said earlier, early on they realized that mifepristone was very effective at killing the embryo, but it wasn't always that effective at causing the uterus to contract and to empty the uterus. And that's why they added the second drug, and then all the subsequent studies looked at both drugs. But at the mifepristone-only studies, there was a 60 to 80% completed abortion rate, like I said before, so a 20 to 40% incomplete abortion rate. The embryo survival rate is unknown. I'm going to quote some data later, but it's really a bit nebulous. For those of you who are interested in biochemistry, this is the mifepristone molecule right here, the 3D version. And you'll see that it is similar to the structure of progesterone right here. And it makes sense because they both can latch on to the very same receptor. Let's look a little bit about the physiology and the pharmacology of mifepristone, not to bore those of you who are not medical, but just to kind of tie things together for those of us who are. It actually was first studied for its anti-glucocorticoid properties. Not only does it block progesterone receptors, it also blocks cortisone receptors, because there's a whole family of hormones which include testosterone, estrogen, progesterone, and cortisone, as well as a few others, that are all basically made from the same molecule, which is cholesterol. Cholesterol is modified. These are all called steroid hormones, and cholesterol is a sterol. And so all of these receptors are relatively similar. So a blocker or antagonist that blocks one is very likely to block the other. And indeed, mifepristone is available under another brand name to treat a condition called Cushing's syndrome. And it's not a common treatment for that, but it is used quite effectively. It also was studied to be used for endometriosis, and it was even studied for use as a contraceptive. When it's taken, about 70% of the drug is absorbed into the bloodstream. But then whenever something is taken through the stomach, the first place it goes, because of the way the circulation is set up, is to the liver. And that makes sense because we want the liver to detoxify things so that if we happen to eat something that's poisonous, it goes first to the liver can tear it apart and break it down so that it doesn't poison our whole body. So this happens with drugs too, and this is something that's sometimes helpful for certain drugs that need to be activated. They go to the liver first, they get activated, they become an active byproduct, or it's also can work to a disadvantage if you're taking a medication, it goes to the liver, it gets broken down before it gets to the rest of the body. Well, here with this drug, about 40% of it is available once you've taken it because of that, what we call the first pass effect of the liver. So that's important to keep in mind as we look at the protocol a little bit later. Now, this is a typical liver enzyme that breaks it down. But what's important here is that there are 3 breakdown products that retain activity. They can still block that progesterone receptor. And those metabolites or breakdown products are in the blood for another 72 hours after it's taken. So that's quite a long time that we see it. And that was guiding my thinking when I set up this protocol on how to treat and reverse this. So 72 hours later, you can measure those metabolites. I talked about the progesterone receptor. It's part of a superfamily. This is a little cartoon just showing what it would look like if you could shrink yourself down to the molecular and the receptor level. This purple is the schematic of the receptor. And then here is that mifepristone molecule that we saw earlier, and shows it docking on the receptor itself. Now, an analogy I use a lot of times when I talk to lay audiences is that the hormone and receptor often described as being like a glove and a hand. That if you have the right size hand and if it's the correct side, it will fit into that glove. And as the glove goes on, you can see here the glove conforms to it. So probably as the hormone or the blocker gets onto the receptor conforms to it, and it causes a change, so it kind of latches onto it. The other analogy is that of the lock and key. If you can imagine a key, the proper key fits into a lock, it turns the lock and the door opens. Well, we can imagine that door opening being what we consider the hormone effect. That's what we want to happen. But many of you have probably had the experience of having used a key that fit into a lock, but it didn't turn the lock, right? And so we call that a false key. And so that exactly is what the mifepristone does. It's the false key. It fits into the lock, but it doesn't turn the lock. And if we can imagine if the mifepristone binds to the receptor twice as well as the progesterone does, which is in fact the case, well, we can imagine then the progesterone key fitting into the lock and staying in the lock for 1 second and then coming out, going back in, coming out every second. While the mifepristone, the RU46, the false key, goes into the lock, but it stays in there for 2 seconds. It stays in there twice as long. So it stays in there for 2 seconds, then it comes out. So there's still a competition there, but the odds are stacked in favor of the false key because it occupies the receptor twice as much. So that's how the mifepristone can block that receptor and block that door opening, which is the hormone effect. You can also look at lookalikes. This guy looks like the Terminator, but he's really a girly man. Well, this is the true Terminator right there. Let's look at another schematic of the receptors. And this is a little brighter. This one's a little brighter. So here you have the progesterone receptor, PR, and you have probably an alpha and a beta side. The alpha side, or the beta side, takes the agonist, or the actual hormone itself, or anything that acts like the hormone. And it attaches right here to where it says PR. You probably have some coactivators, and they cause RNA transcription. The DNA is the blueprint. The RNA is the copy made of the DNA whenever you have a hormone effect. And then that transcribed RNA goes on and gets translated in another part of the cell to proteins. Those proteins affect carry out the effect of the hormone. On the other side, though, let's say you have the alpha side. Here, the antagonist, or the mifepristone, latches on, and that causes everything to come to a screeching halt. So this is how it works on a biochemical level, how the antagonist might work. Okay, now we're coming back to the study I mentioned earlier, and these are the 6 patients that we studied. Right here, their gestational age, how far along they were in the pregnancy. So we can see from 7 to 11 weeks. This is the interval of the time they took mifepristone to when they got their progesterone. And it was from 7 to 72 hours. Most of them got progesterone intramuscularly, an injection, although this patient got first vaginally and then later got an injection. And we had 4 out of 6 healthy term newborns with no birth defects, no problems whatsoever, up to 72 hours out. So this really got us very excited, and that's why we published the paper and got more and more people interested in it. Now, looking at our statistics from 2012 until April of this year, we've had 841 calls to our hotline, and of those, 35% of the women have who were pregnant and were thinking about reversal chose to start the progesterone reversal. We're now up to 91 births, and about 75 are currently pregnant. Our current success rate, looking at this at that point in time, was 56%. Through our range has been consistently from 55 to 60%, usually up to 58 to 60% most of the time when we've done our data analysis. It obviously changes as we go through time. Birth defects, we've had 1 port wine stain. A port wine stain is what we call a vascular marking, or often called a birthmark. So really not a serious consequential structural defect. And other than that, we have had no problems, no complications whatsoever. In the general population, the average rate quoted for major birth defects is 2 to 3%. So we think we're doing very well here, close to 100 births. So far, we've received phone calls from women in 45 different states, and we've gotten calls from women in 13 foreign countries. So this is really becoming an international movement. This is a text message from a woman that we helped. I'm just going to go ahead and read it. Hello, Liz. I just got home. Yes, I got the shot, and I'm going to return tomorrow also. I just wanted to say thank you from the bottom of my heart. You really saved me. I knew I had done wrong. It was by chance I got your number, and I am so glad I did. I feel relieved. You're my saving grace. God bless you, Liz. So I think if you count the number of exclamation points in that text message, you'll see that she's very satisfied and quite grateful. And this was the first woman I helped. This was the woman in El Paso, Texas. And here you see her toddler baby there, who's now about 5 or 6 years old and doing very well. And this is Terry Palmquist, the woman who helped me, who's from Bakersfield. Okay, let's talk about birth defects, because women often ask about birth defects, and there's sort of a great paranoia in our society about birth defects. It's very interesting that for 1 minute the woman is ready to, or has taken a medicine to kill her baby, and you may see this in women you're counseling who are in crisis pregnancies who are thinking about having an abortion. 1 minute they're ready to abort or kill their baby, or they've already attempted to. The next minute they're going to take something that's going to try to reverse that, and their first question is, well, what about birth defects? Could this harm my baby? They've already done something to ultimately harm the baby, and now they're worried about birth defects. But nonetheless, these are genuine concerns, and we have to address them. So if we look at the different birth defects that have been detected in studies, we can look at the birth defects associated with misoprostol. That's the second drug that causes the uterus to contract, also called cytotec. And there have been a lot of facial paralysis, something called the Mobius syndrome that I'll talk about in a second, and problems with the arms and legs being shortened. When you look at women who've been exposed to both drugs, the mifepristone and the misoprostol, the birth defects are exactly the same. And when you look at this data for mifepristone alone, you can see that there's really a lack of data that it can cause birth defects. So our conclusion is that misoprostol cytotec, the second drug, does cause birth defects. When you take both together, the birth defects are just like the ones if you just took misoprostol alone. Mifepristone, no good evidence that it causes birth defects. And I have to say that we have lots more data on misoprostol. The reason why is that around the world, misoprostol is used, like I said, in all these countries where abortion is illegal. And so misoprostol is used a lot more. In other countries where mifepristone just is not approved, they use misoprostol for medical abortions. The Mobius syndrome I mentioned, this is a birth defect caused by misoprostol, the second drug, cytotec. And it can cause paralysis of various cranial nerves, so facial paralysis. It can cause abnormalities of the development of the face, of the cranium, sometimes the brain, of the mouth. And it's often associated with limb reduction deformities. That means that the arms and legs are not as long as they should be. The critical period appears to be between 5 and 8 weeks gestation. That's what the critical period for exposure. And of course, that's exactly the time when women are taking these medications for the medical abortions. And to date, mifepristone RU46 alone does not appear to cause the Mobius syndrome. This is a common textbook used to look up drugs in pregnancy. It's called Drugs in Pregnancy and Lactation. And in their chapter on mifepristone, they note that it causes birth defects in rabbits, not in monkeys or rats, and that the data in humans is insufficient to judge. The American College of OBGYNs, which has been critical of our protocol, published a practice bulletin in March of 2014, and in that practice bulletin they state that mifepristone is not associated with birth defects. So that's the official word from ACOG. There are a few studies in the literature. Right now we're planning, because of this question, we have started a literature review, and we're going to publish a paper looking at all the studies on mifepristone and birth defects, and also we'll be looking at misoprostol also. But this study was looking at women who had taken either mifepristone alone or mifepristone and misoprostol, and whose babies survived the medical abortions, and seeing what the outcomes were there as far as birth defects. So a total of 105 pregnancies were included, and the overall rate of congenital or birth defects of congenital abnormalities was 4.2%. And like I stated before, the quoted statistic usually is 2 to 3% of pregnancies have major birth defects, although some studies will show up to 5%. So this is well within that range. And the conclusion of these authors was that The rate of major malformations after first trimester exposure to mifepristone is only slightly higher than the expected 2 to 3% rate. So they found this to be very reassuring, and indeed it was. Now, looking at misoprostol by itself, several studies, some out of Argentina, and in this study, the odds ratio was 2.2, and what that meant was that the rate of malformations was approximately doubled in patients who had taken misoprostol, so from 2 to 3% to 4 to 6%. This was a study from Argentina, and here the relative risk, same kind of thing, was 2.27. That means that the rate of congenital malformations or birth defects was more than doubled in this study of patients who are exposed to the second drug, misoprostol. This was a meta-analysis looking at several studies, and here it was, the odds ratio was 3.5%. Again, what that means is that the rate of malformations was increased by 3.5 times. So from 2 to 3%, it went up to 7% up to about 15%. This was an interesting study out of France where women who had failed medical abortions, they called a birth defect registry in France. And so these birth defect registry, it was an office of the government health ministry, decided they were going to use this to publish some data. And so they got a total of 71 calls from women who had failed medical abortions. Out of those 71, 8 of them had birth defects. So that's about a 12% risk of birth defects there. So 8 out of 71 had birth defects. Out of those 8, 7 of them had received a misoprostol-like drug called Gemiprost. Gemiprost is another prostaglandin analog. It's not used in the United States or even in other countries these days for 2 reasons. One, it's a lot more expensive than misoprostol, and number 2, it's heat sensitive, so you have to take care that it doesn't get in an area that's exposed to too much light. And so nowadays it's mostly misoprostol, but in those days they were using a lot of Gemiprost. And there was, so 7 out of the 8 who had birth defects took both drugs, while 1 patient had taken the mifepristone, the RU46 alone. And this patient had a serenomelia and a cleft palate. Serenomelia is often called the mermaid type defect, and it looks like this, where the legs are fused together. And it's commonly associated with other kinds of complications. So in this case, it probably was not related to the mifepristone RU46. Well, then after I've talked to the women about birth defects from the mifepristone, the next thing they always ask is, well, you're going to give me progesterone. What about birth defects that can be caused by progesterone? And this was an article in the archives of pediatric adolescent medicine. And they found that women who had taken a progestin, and a progestin is the large category of hormones and hormone-like drugs that have progesterone-like effects. That's why they're called progestins, not progesterone. And it found that women who had taken that, they had a higher chance of their male babies having a defect of the penis called hypospadias. Hypospadias is where the opening of the penis, instead of being at the end of the penis, it's along the shaft. However, in this study, there was no distinction made between whether the women received progesterone, the natural hormone, or if they received an artificial progestin. So in 1999, the FDA conducted a review and felt that there was no risk of birth defects, including hypospadias in pregnant women who were taking progesterone or 17-hydroxyprogesterone. So this was very, very reassuring, a stamp of approval from the FDA. And indeed, the progesterone, what we call natural progesterone or bioidentical progesterone, has been used in pregnancy very safely and effectively for over 40 years. So we're very, very happy with that track record. And Dr. Thomas Hilgers in Omaha, Nebraska, the founder of NAPRO Technology, he has a large series of women who've taken progesterone in pregnancy. And in his group, the rate of hypospadias was 1 in 1,000, while in the general population, it's 1 in 250. So this is not to claim that progesterone prevents hypospadias, but just to show how safe it is and that it is not causing hypospadias. The American Society of Reproductive Medicine, which is a group that is very disinterested in our work, they could care less whether or not we're reversing mifepristone or not. All they care about is to have better IVF rates and better pregnancy and delivery rates for their IVF patients. And so they use a lot of progesterone in the first trimester because they want to do whatever they can to prevent miscarriage, and there's a high rate of miscarriage in women who've had IVF. And so they said that it's unlikely that progesterone causes any birth defects. So they're very comfortable using it, and they came out with the statement that yes, indeed, it is safe. So I'm going to talk a little bit about challenges and barriers. Now, tomorrow the talk is going to be on the faces behind the numbers, or different women's stories who've had their mifepristone reversed. So much of this I'm going to cover tomorrow. I'm going to cover a few of these today. We've talked about birth defects already, and the others: ambivalence, difficulty tracking, lack of emotional support, abortion clinic pressures, lack of bonding. We're going to talk about tomorrow. But of more importance to us, like I told you about before, is the difficulty in finding a doctor. Because really, if there's not a doctor in the area where the patient is, the clock is ticking, and we waste a lot of time trying to find a doctor. The other thing is that sometimes if we already have a doctor in the network, and that doctor hasn't talked to his whole staff, all the medical assistants, all the receptionists, and let them know that he's part of our network, sometimes we'll call the office, and they won't know what we're talking about. And what do receptionists at doctors' offices always do? They always build a wall between you and the doctor, right? They're the protectors, and so they may not let our call get through to the doctor, or not until the end of the day. And what happens at the end of the day? Well, that's 8 hours later, and the clock has been ticking. The doctor forgets, has to run off to a meeting, doesn't call us back. So that can be a big problem. So because of that, we are always asking the doctors if we can have their cell numbers. We don't give their cell numbers out to patients, but we want to be able to call them directly so that we don't have to go around the big hurdles of the office staff. And sometimes doctors who are in our network maybe haven't had a patient yet, and maybe they're not prepared yet for the patient to come in. Maybe they don't have progesterone ready. Maybe they forgot to tell their staff how to go about everything. And so again, that can waste time. And anytime there's a novel protocol or something that's new being done in an office, it always takes time for everybody to get used to it, and there can be pitfalls and delays with that. Sometimes the doctor forgets to buy the progesterone, or sometimes the progesterone has expired. Without the progesterone in the office, that can be a problem if they want to give the intramuscular injections. They have to keep an eye on the expiration date. With the compounded progesterone that most doctors usually use, the expiration date is anywhere from 3 to 6 months. So if you're only getting one of these patients every few months or twice a year, you can imagine the progesterone could expire. So there's been a lot of opposition from the medical establishment and others. The others, of course, being the people who call themselves pro-choice. And so, but they often contradict themselves they often tell them that reversal is unlikely, but they also say, well, the mifepristone is ineffective. If they just do nothing, they're probably going to be fine. Well, then why would they use the mifepristone in the first place if it wasn't effective, right? And they exaggerate the mifepristone failure rate, which we're going to talk about in a second. They call new science junk science. They state that there's no proof of the success of reversal, despite our experience with over 90 patients having given birth and another 75 pregnant. And they're hypocritical. They attack off-label usage of the progesterone. And they also dismiss the possibility. They just can't fathom how a woman might change her mind and not want to do an abortion. So let's look at the mifepristone failure. And I touched on this earlier, but to go into it in a little more detail. I told you the incomplete abortion rate is 20 to 40% with women who take mifepristone only. They've been bandying about this 50% figure. I don't know if anybody of you reading the press, but we've looked at all the studies, and we've yet to find a study that says that mifepristone causes incomplete abortion in 50% of the cases. That 50%, somebody I think made it up, and now everybody's propagating that. So that's one of the reasons why we're going to do another study. We're going to do a literature review of mifepristone failure rates, so we can finally say these are what the studies actually show. Let's talk about real numbers instead of just making numbers up. And again, incomplete abortion means that the uterus was not completely emptied. It does not imply that the embryo survived. Okay, so that's very important. But they're making the assumption, incomplete abortion, the baby would have survived If you do nothing, everything will be fine in 20 to 40% of the time. In the early studies, there were some quotes of embryonic survival. And in the different studies, those rates quoted were 7 to 40%, so quite a wide range. We have to be careful interpreting that also, however, because in all those studies, the early chemical abortion studies, they had a surgical abortion set up as a backup in case it didn't work. So even though they were able to probably detect a heartbeat, they saw the baby was still alive, those women then went for surgical abortions. So we don't know if that baby would have survived all the way to term. And a woman who comes to us for reversal, she wants to know if she can have a baby born and that she can raise for the rest of his or her life. She's not so interested in whether it's an incomplete abortion or complete abortion, or if the embryo, the baby survived initially. So it's very important to see what the desired outcomes are. The claim that it's junk science, well, I say it's not junk science, it's new science. Anything that's new, any novel idea has to start somewhere. And just like new drug discovery started somewhere, this started with just one patient, and then it grew to 6 patients. Now it's grown to about 150, 170 patients. And we have a lot of science behind this. We know, like I just explained to you, how the receptors work, that progesterone latches onto receptor, it causes the hormone effect. The mifepristone, we know, binds to that receptor, but doesn't cause the hormone effect, therefore it's a progesterone blocker. So that's very well understood. And there are also rat studies out of Japan where they gave these rats, one group of rats only got mifepristone RU46, the other group of rats got both mifepristone plus progesterone. And the rats that got just the mifepristone, they aborted their babies. They had changes in the ovaries and the corpus luteum. They were typical of mifepristone. The rats that got mifepristone along with progesterone, all of those mifepristone effects were negated. They did not abort their baby rats. The corpus lutea did not have the changes that were characteristic of those that got the mifepristone. So we have biological evidence there that progesterone indeed does block the effects of mifepristone. So that's been proven in rat models. And then we know that mifepristone causes a complete abortion or an incomplete abortion. This is a typo here. Incomplete abortion 20 to 40% of the time, and the embryo may survive 7 to 40% of the time. Our success rate of 60% is certainly far better than the 7%, and it's much better than the 40%. So even if we take them at their word using these numbers and assuming that 40% would survive, 60% survival is still a lot better than 40% survival. But like I've explained, it does not appear that 40% would truly survive to deliver if you just did nothing. How about the charge that we've been criticized for using progesterone in off-label fashion? And indeed, progesterone, we are using it in an off-label fashion. However, it's important to remember that there is 40 years of experience with progesterone in pregnancy. Progesterone is a generic medication, the injectable. And so all of you who are familiar with drug studies and FDA approvals know that it's an extremely expensive process to have a drug approved for any particular indication. That's probably millions, if not hundreds of millions of dollars of studies. So when there's a drug that's generic, there's not that economic potential to reap the benefits of that investment. So no one's ever going to study progesterone for all the different uses in pregnancy. It's been used for 40 years. Everybody assumes that it's safe, and everybody continues to use it. This other drug that I mentioned earlier called 17-hydroxyprogesterone is very similar to progesterone. It just has a hydroxy group tagged onto it. And that was studied and was approved by the FDA for use in pregnancy for women who have had a history of preterm deliveries. And that 17-hydroxyprogesterone is given throughout the entire pregnancy until about 36 or 37 weeks to prevent another preterm delivery. So we have that safety and approval there. But it's hypocritical for them to say, well, you're using your progesterone in off-label fashion, because if you recall in our earlier slides, their mifepristone protocol that they're using right now is an off-label protocol. That's not the approved protocol. So it's very hypocritical for them to attack us on that when they're doing the very same thing. How about people changing their minds? Well, all of you know, that's the whole thing about redemption, right? We change our minds. We decide not to be sinners anymore. We're going to follow the Lord, right? So people do change. Thank God we can change our minds, right? And that we have the free will to do that. And we have the grace of God always urging us to go towards the good. Well, people do change their minds. And a lot of the studies done on the psychological aspects of abortion, where these are studies that they quote saying that, well, women rarely change their minds and they're rarely indecisive. These are all women who are interviewed right after they've had the abortion. And if you know anything about cognitive dissonance, you know that when your mind is thinking one thing, but your actions are doing something opposite, your brain doesn't like that. And so you will change one or the other. You either change your behavior to correspond with your beliefs, or you'll change your beliefs to correspond with your behavior, right? All of us have done that at one point in our lives, or we've witnessed that in others. Well, so these women are being interviewed right after they've had an abortion to kill their unborn babies. You think they're going to say, that's the worst thing I ever did? No, they're going to say, it's something I had to do, and I'm glad I did it, et cetera, and that's the narrative. Well, even in those studies, which are very biased because of the design, about 10% of the women showed some indecision and some ambivalence. So even if we take those very biased numbers, and let's say that 10% do have some ambivalence and may change their minds, well, how many people is that in this country per year? 20 to 30,000. So that's a significant number. So why not offer something that 20 or 30,000 people would appreciate it and might want to take you up on the offer? But when you look at other studies, and there's a psychologist, Dr. Priscilla Coleman, who's done a lot of studies. You might want to look up her work if you're interested in this. She's done more longitudinal studies, and her studies are structured differently, so there's not the bias, the pro-abortion bias. She really tried to dig in and see what the patients were thinking at the time of the abortion and months and even years later. And she's seen that once that cognitive dissonance effect wears off, that sort of the women realize what they've done, that there is a lot of ambivalence, there is a lot of regret, and the numbers then go much higher. So if you take those into account, then that 20 to 30,000 women per year probably goes up much higher, maybe to 100,000, who knows. But we see that there's a great deal of indecision and second guessing and regret. So are these opponents really pro-choice when they don't want to give women a second chance, or are they just pro-abortion? That's the question I ask them, because they don't want to give women a second choice. So they're really not for choice, in my opinion. So it's just a bioethics conference, so I thought I'd talk a little bit about some of the bioethical issues. First is autonomy, and that's, of course, the right of the person to direct his or her own course. It's an issue both initially and subsequently to the medical abortion, because does the woman have a right to change her mind? And of course, if you honor the ethical principle of autonomy, you would say, yes, the woman has a right to change her mind and has a right to take another course. Autonomy and non-maleficence. Non-maleficence is the principle of doing no wrong. And there really should be valid informed consent, including information on reversal in abortion centers. And this is lacking. I think if you talk to women who've gone to abortion centers, they really don't get a good informed consent most of the time. They tell them that this is the right thing to do, that this is a blob of tissue. They don't show them the ultrasound. So it's really not an informed consent procedure. And if they're not telling them about the possibility of reversal, then they're definitely not giving an informed consent. And then the abortion centers not only not giving the information, they're also misinforming them. They're lying to patients, or they're misinforming them, telling them that reversal would be risky, that it would be ineffective, and that the chance of birth defects would be great. And these are all lies and misinformation. This is commonly what women tell us that they've been told at the abortion centers. The ethical issue of justice. The embryo has the right to a safe and non-threatened pregnancy, of course. The embryo also has a right to be rescued from a medical abortion. So that's just the right of the embryo. And beneficence is giving a mother and a father a chance to redeem themselves, and that's always a great gift. Autonomy is important in the pro-life office, too. We have to remember that when we're counseling these women, that we cannot use deception or coercion, that we have to give them the facts, we have to give them gentle support, we have to give them pastoral guidance. But if we're coercing them, or if we're giving them misinformation or not being transparent, then we're not granting them the autonomy, and they have the right to exercise their free will and to do that in an informed environment. Okay, so let's come to some conclusions now. Mifepristone reversal using progesterone has been shown to be safe and effective. And our growing case series supports this conclusion. Our goal is to have the progesterone outcompete the mifepristone at the receptor level. Like I told you, we want more good soldiers to outcompete the bad soldiers. There's no scientific evidence suggesting that mifepristone increases the risk of birth defects. And progesterone and 17-hydroxyprogesterone caparate are safe in pregnancy, no doubt about that. So in considering the protocol, I looked at the molecular weight of the progesterone and of the mifepristone. They weigh about the same. Their half-lives are pretty comparable. And the mifepristone, like I said, there are active byproducts up to 72 hours out after taking the pill. And the mifepristone binds twice as avidly as the progesterone, so it latches on twice as well to the receptor. So it seemed that because of that, if we could dose it at twice the amount, or at least at the same amount, because half of it is gone after going through the liver, that we'd be on an even playing field. And using the most bioavailable method of delivery, we chose to use intramuscular or injected progesterone. And that's 200 milligrams intramuscularly, which is the highest dose I usually recommend. And this is our protocol. We give 200 milligrams intramuscularly as soon as possible after the ingestion of the mifepristone. Like I said, we've had success up to 72 hours. Our goal is to try to get the progesterone on board within 24 hours. And then we try to get an ultrasound as soon as possible. Number one, to confirm that the baby's still alive, because we don't want to treat a dead baby. Number two, to confirm that the baby's in the uterus. We don't want to give progesterone to a woman who has a tubal pregnancy. But if you can't get an ultrasound right away, we don't recommend delaying the progesterone. Give the progesterone and get working on the ultrasound as soon as you can. But we don't want to delay the progesterone. If the baby's less than 6.5 weeks along, you may not see anything in the uterus, and so you might monitor the HCG levels, but we have to caution you that monitoring HCG levels may not be as straightforward as with normal pregnancies because of the effect of the mifepristone on the corpus luteum, which produces progesterone. So monitor those, or interpret them very carefully. The baby may not be dead when you think it is. Then we'll repeat the progesterone for 2 more days in a row so that it's 3 days in a row. Then every other day until 2 weeks have passed since the ingestion of the mifepristone, and then twice a week until the end of the first trimester. Now, some women refuse to have injections. I don't like shots myself, and sometimes doctors don't have progesterone injectable in the office, or for whatever reason they don't want to give progesterone injections. So we have alternative protocols here. The 17-hydroxyprogesterone caparate is very, very expensive, so we usually don't use that. And medroxyprogesterone acetate, also known as Provera, which is a common progestin, has been associated with hypospadias. So we don't recommend using that. We do recommend, though, in these cases, as you can get progesterone compounded vaginal suppositories, 400 milligrams, one taking at night every night until the end of the first trimester, or you can get off-the-shelf progesterone oral capsules, often called Prometrium, and you can take 2 capsules self-administered vaginal each night, or 2 capsules orally each night, or twice a day, some doctors have been using. And we've been surprised by the effectiveness of the oral regimen. In a small subset of data that we looked at from 2014, this actually looked very good. I'm not ready yet to advocate this as the first protocol. We're going to wait till we look at all of our data for about at least 100 births before we change that. But that is promising. Some clinicians will monitor progesterone levels after the first trimester and continue progesterone later on in the pregnancy if the progesterone levels are low. And they usually follow the protocols of NAPRO technology developed by Dr. Thomas Hilgers. So in getting ready for the protocol, you want to have progesterone and oil on hand. We recommend getting the compounded progesterone 100 milligrams per ml because it's a smaller volume injection. You can also get progesterone off the shelf, but it's 50 milligrams per ml. This has the advantage of being more readily available, but it's a higher volume injection. You have to give 4 ml, so usually you give 2 mLs on each side. If you do get compounded progesterone, you find one in your area that you can trust. The International Academy of Compounding Pharmacies is one place to look. We have a list of compounding pharmacies that we can give to those who are in our network. A lot of our doctors have used Kubat Pharmacy in Omaha, Nebraska. They have probably a 30-year history of making progesterone. And we use Central Coast Pharmacy. They're a pro-life pharmacy on the West Coast, and they will ship just about anywhere. These compounding pharmacies, they'll ship to you if they have a license in your state. So depending on what state you're in, you have to figure that out. Those of you who are giving, the important thing is to give the injection up high and laterally to avoid the sciatic nerve, but also if you give it too low, it's going to cause more inflammation. So you want to give it up high. And give it very slowly by the clock over about 2 minutes. It's important to be available. That's the most important thing because, like I said, time is of the essence. How do these women find us? Well, they go online, and then they call our hotline. This is our website, abortionpillreversal.com. Tells good factual information on how medical abortion is performed, the side effects of RU46 mifepristone, stories of regret that are real stories, and success stories of women who've successfully reversed the mifepristone. There's a doctors and PRC tab that's password protected. You go there if you're part of our network, and we give you lots of resources. If you want to see this talk again, there's a similar talk posted on the website under the doctors tab. Right now, like I said, we have over 270 doctors in our network and growing, and any of you who are interested, please let us know. We're inviting all doctors, nurse practitioners, midwives, and PAs who are interested to join our network. Our goal is saturation across the country and eventually around the world. We had an APR press conference in February at the National Press Club with Father Frank Pavone and Priests for Life. This was a couple who successfully reversed the mifepristone. I'll be talking about her case tomorrow. And when Arizona and Arkansas passed laws recently saying that abortion centers had to tell women about the possibility of reversal, this created a big firestorm of controversy and a lot of press coverage. So we got a lot of publicity. Most of it, I think, was good, although most of the articles were biased. I was interviewed by the Washington Post, New York Times, Los Angeles Times, the San Diego Union Tribune, MTV, believe it or not. Atlantic Magazine did a story but didn't interview me. American Thinker did a story. BBC Mundo did an interview. Canadian Broadcasting Corporation Radio interviewed me for their program, and National Public Radio. So a lot of publicity there. So we're calling out pregnancy resource centers and pregnancy medical clinics. With the medical director, they can be in our APR network. They can serve as a hub because the PRCs do what's so important here. They provide support and follow-up. So free all this up from the doctor so the doctor's busy office doesn't have to deal with all that. They can make phone calls and follow up patients. And if it's a medical clinic, the RN can administer injections with a physician order. They can keep progesterone if it's a medical clinic in the office. Schematically, this is how it would work. The APR hotline, the patient calls us. We connect them with the pregnancy resource center or pregnancy clinic. They interact with the doctor. Patient mostly interacts with them, interacts with the doctor. The doctor should see the patient within 3 days of starting the protocol. These are all the resources we have: a 24/7 hotline, consent forms, supportive follow-up as needed, model standing orders, policy and procedures, the protocol, an APR kit, which I'm going to show you, and advice from nurses and from me as needed. This is our kit right here that Dr. Matthew Harrison developed, and it's a very handy kit. It has all the instructions on the back. Inside, we have all of our documents that you'll need. There's a place here to put the progesterone vial, and then here's a place to put needles and syringes. So this is a one-stop place to have on the shelf there at your center or in the doctor's office. So when that patient comes in, you don't have to scramble around to find everything you need. You just go on the shelf and you see, there's our kit. You grab the kit and you can treat the patient. So I will leave that on the table there. One lucky person who comes and grabs it can take it, so I don't have to take it back home. So that's our kit. Patriot Insurance Agency is committed to APR coverage. So for your pregnancy resource centers, they will cover your clinic for any malpractice issues related to APR. So a specific APR rider, it's called Patriot Insurance Agency. You can look them up on the web or call us for them. We have a four-pronged approach of outreach. You want to get into emergency departments, primary care offices, PRCs, OBGYNs. If you have any questions or want to join our network, we welcome you to join. You can call Sarah Littlefield or email apreversal@gmail.com. You can also get to that through our website, abortionpillreversal.com. Any of you benefactors out there, it's tax deductible. This is a project of Culture of Life Family Services, which is a 501(c), so all your contributions will be tax deductible. Thank you very much for your time and attention.